Hi, I am presenting a case of total laparoscopic hysterectomy for an adenomyosis in which the patient had a ventrofixed uterus, that is, a fixation of the anterior wall of the uterus to the anterior abdominal wall due to previous surgeries. This patient had two previous LSCS, and we can see that the anterior wall of the uterus is completely adhered to the anterior surface of the post anterior wall of the abdomen. So we began the surgery by dividing the obvious band midway between the uterus and the anterior abdominal wall, as the superior surface of the bladder may come close in this area. So initial few bites we were taken with the vessel sealing device. Later, when we learned that we were going very close to the superior surface of the bladder, then we changed our energy source to the harmonic, which has got a less lateral spread, more control over the dissection. So we can see that it looks like a dense scar has appeared, a vascular adhesion has formed between the uterus and the abdominal wall. We are keeping the dissection midway between the uterus and the abdominal wall. Close to the abdominal wall, we are going close to the bladder, and close to the uterus, as we cut the myometrium, there is a possibility of retraction and the chances that it will bleed more. So better to keep the dissection midway between the two structures, and it is better to divide the fibrotic tissue, then we will get a exposure to the deeper down tissue. So we can see now we are changed over to the harmonic scalpel, which has got a less lateral spread and less smoke production when we examine when we do the surgeries. So we can see that we are observing, we are finding that plane between these two, and try to cut the fibrotic tissue, not the any other structures which inadvertently may include the superior surface of the bladder. So once we are using both blunt and sharp dissection, a snip of fibrotic tissue is being divided, and then gently it is nibbled away so that we will get more space for the dissection. So we can see that just dividing and gently pushing it is both sharp and blunt dissection, and every time we identify the fibrotic tissue fiber by fiber, then we divide them. The previous surgery of cesarean section, which was done 7 years back, must have led to infection, and that has led to this adhesion formation. So here the bladder must have been, superior of the bladder must have been adhered to the anterior abdominal wall, and later we are supposed to separate the base of the bladder from the cervix. So we have to keep in our mind that two part of the bladder needs to be separated in this area. One, this is the superior surface, we are separating it, and as we go down, as we go close to the cervix, after the uterine vessels are seen, but before dealing with the uterine vessels, we have to separate the base of the bladder from the cervix. That we do it as routinely. So this is the additional adhesions which are not normally present, which may be sometimes a cause for a injury to the bladder if we are dividing it a little less carefully. So you can see that the division we are doing midway between, we are not digging deep into the uterus, which the myometrium may retract and it may lead to bleeding, and you are not going close to the abdominal wall. We are going midway between them. We are trying to identify the fibrous tissue and then we are dividing it. So that's the best way of division at this in a ventrofixed uterus. So as it is a dense fibrotic tissue is there, there's enough space is there to divide this area. So once we divide this, it gives way to the tissue below it and gently nibbling it away from the uterus will give more dissection. So as we go down, now we are coming almost close to the isthmus of the uterus. So once we come close to the isthmus of the uterus, we can understand that we can identify the uterine artery and go superficial and medial to it, where we can have a avascular plane between the bladder and the cervix. So this is the dissection. We are continuing it onto the right side near to the round ligament. So now we are trying to divide the coronal pedicles. So before going to the coronal pedicle, a small dense fibrous tissue of omentum adherent to the round ligament is divided, and we are trying to divide the mesosalpinx. Later we'll tackle the ovarian ligament and the round ligament as we do it routinely. So once these ligaments are divided, then we can have further exposure to the ovarian vessels, uterine vessels. So when we get exposed to uterine vessels, we can keep the dissection superficial and medial to the uterine vessels. Then we can get a lateral window of bladder to get access to the avascular place between the cervix and the bladder. Now we are dividing the right side round ligament and mesosalpinx is being divided, and we are going to the broad ligament. So now we are reaching the ovarian ligament. So once we divide the ovarian ligament, we can reach the broad ligament, where we can identify the uterine vessels. So identifying the uterine vessels is helpful in getting the lateral window technique of separating the cervix from the bladder. As we can anticipate, even the adhesion of the bladder or the base of the bladder to the cervix also may have a dense fibrotic tissue. But as we go in a proper plane, it gives way to a anatomical dead space that are present between the cervix and the bladder. So these are the few fibers of the broad ligament we are reaching. Now we will do the similar dissection on the left side, tackling the coronal pedicles before we reach to the isthmus of the uterus. Routinely we finish the surgery one side first and then go to the opposite side, because here we are having a very dense fibrotic tissue. Dense adhesions are there. So we try to first tackle the coronal pedicles on either side first and have a good exposure of uterine vessels on either side. Then we can separate the cervix from the bladder, base of the bladder. After that, we can go and tackle the uterine vessels. So these are the band of adhesions that are present near to the site of the tubectomy thing. Gentle dissection and fiber by fiber dissection, and identifying the each and every structures before dividing them is a clue in such cases of where dense adhesions are present. So whatever the anatomical structures are identified, can be identified on those structures are divided first, and then we can go and tackle the remaining tissue. So now this is the broad ligament posterior leaf near the isthmus of the uterus. We are dividing it till the uterosacral ligament is identified. So we are just dividing the peritoneum. We are not going even deeper to the peritoneum, so that we can have exposure of underlying vessels, underlying components of the broad ligament. So that's the uterosacral ligament is divided. So now some fibrotic tissue is present near to the isthmus. So this may contain some of the vessels, some of the veins are present in this fibrotic band are being divided. So once we divide this, now we can have a exposure to the uterine vessels, which I am holding it in the left hand. Very easily we may go into the wrong plane. So every time identify the anatomical structures and then continue with the dissection. So whenever you see a fatty layer, better to keep superficial and medial to this area and push the fat towards the bladder. So that is uterine vessels were identified, and then we are keeping the dissection superficial and medial to it. So this is the dense fibrotic tissue that is not giving the further dissection. It's not giving way to the anatomical dead space that is present here. So once we divide this, then we can have an exposure to the cervix. So we are identifying this with dense fibrotic tissue. We are just dividing the adhesions. We are not going any close to the bladder or the uterus. Instead, we are just dividing it close to the uterus. So now almost superior surface of the bladder is completely separated from the uterus. Now we have to separate the base of the bladder. So we should not think that just because the bladder superior surface is separated, now we are safe. But still, as routinely we do, the base of the bladder, we are separating it from the cervix. Now we have to tackle it. Still, this is the some part of the superior surface of the bladder. Still, we are yet to reach the heart. So that is the bladder. I am holding it in the left hand and try to find a way between the base of the bladder and the cervix. And keeping the dissection very close to the uterus, but not dividing the part of the myometrium. holding the bladder itself is a good way to find the plane and dividing only the fibrotic tissue. So that is the cervix. We are almost reaching near to the cervix. Smooth, shiny area we should be able to reach. So this is in the left hand I'm holding the bladder and dividing the fibrotic band that is present between the cervix and the bladder. So we are using the uterine manipulator with the cervical cup, so which is showing the cervix delineating from the vagina. So that is the edge of the cervical cup of the uterine manipulator. So those are the few bands of the bladder pillar. So that is almost we have reached the final part of the dissection. Now we can tackle the uterine vessels. Since the base of the bladder is completely separated away from the cervix and upper part of the vagina, now uterine vessels are being divided, coagulated, and then they are divided. So vessel sealing device is a good instrument to seal the vessels, but harmonic scalpel is a very good instrument for the dissection. So we should understand our energy source, where it is better used. The sealing of the vessel sealing device is very good. So though their tortuous vessels are there, so it is very easily sealing them and then easily allowing them to divide. So better to divide them, use the vessel sealing device in a short burst of maybe 2 or 3 seconds instead of coagulating them continuously, which may lead to charring of the tissue. So charring of the tissue will not give a good hemostasis. Just blanching is sufficient, which gives a very good thick coagulum which seals the vessels completely. So we have almost come close to the dissection and the division of the pedicles on the left side. There are a few fibers of the bladder near to the cervical cup. That's the indentation of the cervical cup we can see. So now this completes the hysterectomy on the left side. Now we can go to the right uterine vessels. And right transverse cervical ligament. So now we are going, this is the right side uterine vessels is being tackled now. So repeated small bursts of energy source are very important in a vessel sealing device. Instead of going for a long duration of sealing, which can lead to a black issue formation, which is not good. Instead of that, this is the white blanching area, which gives a very good coagulation of this area. So that is the uterine artery. We are able to identify it, seal it, and then we can divide it under vision. Here we can appreciate the importance of vessel sealing devices, where they can completely seal the vessel and also helpful in dividing them.
I start my day in silence. Where are my slippers? Where's my notebook? My dreams, write them down. Write down your dreams. Write down your dreams. Don't forget to write down your dreams. More silence. More silence. And now, it's time to go.
So now we are separating the vagina from the cervix by using a unipolar energy source. Given unipolar energy source also in a repeated short burst instead of continuously dividing them, which can increase the smoke formation, which can obstruct our vision. So dividing a little slowly will have a very good hemostatic division of the vagina from the cervix. And they keep dividing the vagina at the edge of the cervical cup, that is colpotomizer. So now this completes the. So now this is a retrieval of the specimen. This was it was a adenomyosis of nearly 12 to 13 weeks of 12 to 14 weeks of gestation. Since uterosacral ligament from the cervix was divided, we are going to reattach the uterosacral ligament to the vault of the vagina. So lifting the vagina will give a prominent, will make the uterosacral ligament prominent, and then take a bite. So make sure that we do not include a ureter while taking a bite in the uterosacral ligament, which is just a centimeter lateral to the uterosacral ligament near to the vault of the vagina. So usually 2 bites of vaginal tissue we take, including the uterosacral ligament, and then we'll tighten it. On either side we do the same procedure so that approximation of the vault happens with the attachment of the uterosacral ligament back to the new vault of the vagina.
I can tell we need to talk about things, so I'll let you start.
So this is the surgery of total laparoscopic hysterectomy we did for a adenomyosis patient, in which because of the 2 previous LSCS, this patient had a ventrofixed uterus. So there was the adhesion of the complete anterior wall of the uterus to the abdominal wall. So if a care is not taken, there are chances of injuring the bladder at 2 places, one at the superior surface of the bladder and the second at the base of the bladder. That should be kept in our mind. Just because we separate the superior surface of the bladder, it doesn't mean that it is going well away from the cervix. But later, as routinely we do in every patient, so base of the bladder also need to be separated from the upper part of the cervix and the upper part of the vagina to divide it in later safely without injuring the bladder. So this is the second bite onto the vagina, and once we approximate it, so that finishes the surgery. Just have to complete the confirm the hemostasis and then have a check at the base of the bladder if it any or superior surface of the bladder if any injury is done inadvertently during the dissection. If any such injuries are identified, then we can take a stitch and then complete the process.
Why should I repeat myself? 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 Why should I repeat myself?
So here one more way of taking the knot, that is sliding knot we are using, because we took a single knot. We just for a demonstration we are showing the, suppose if a loosening happens or you are finding difficult to take 2 throws in the beginning, so only 1 throw was taken, but still we can complete the so just keep it loose and pull it with the hold the short end. Now tighten the second throw. So this is a sliding knot can be used. It will be useful in some cases where you are finding difficult to tackle the 2 throws in the beginning itself. So 1 throw is taken, over that second throw is taken loosely, and then hold the short end and then complete the tightening of the knot. So this completes the surgery for this patient. So after this we just have to confirm the hemostasis, have a look at the base of the bladder if any injury is present, and then just observe the peristalsis of the ureter on either side, and that finishes the surgery for this patient. So we are just having a look at the base of the bladder and superior surface. So that is, you can see that both the uterosacral ligament are nicely tucked to the vault of the vagina. So that is a complete examination of the base of the bladder and then this is the superior surface. So thanks for watching this video.